The title of this lecture is Principles of Capillary Fluid Exchange. And in this lecture we will be examining capillary characteristics and biophysical principles that determine the movement of fluid across the capillary wall. This slide lists the major concepts that we'll be covering in this lecture. So please review these concepts, especially after you have studied the material, to make sure that you understand all these concepts well. For recommended reading, I suggest that you read pages 186 through 193 of the second edition of my textbook. In the histology lecture that you've already had, you looked at different types of capillaries. And this slide is showing that the three different classifications that Dr. Chatterjee presented to you. On the left, we have continuous types of capillaries. In the middle, we have fenestrated capillaries. And then finally on the far right here, we have discontinuous capillaries. I don't want to go over the details of these three types of capillaries. You've already had that in histology. But what I want to point out to you is that continuous capillaries, which most capillaries are of this type, they're found in skin, muscle, lung tissues, central nervous system. These particular capillaries are less permeable to water and to electrolytes. So we might consider these as being very tight capillaries. So there is relatively little movement of fluid across these capillaries compared to the other types. As we move into the fenestrated types of capillaries found in exocrine glands, renal glomerulus, and intestinal mucosa, these capillaries are much more permeable to water and electrolytes. However, they still do not permit protein to cross the capillary barrier. And finally, we have the discontinuous capillaries, such as found in the liver, spleen, and bone marrow, and these are very leaky capillaries. Let's now look at the topic of capillary fluid balance and exchange. As I indicated to you, continuous capillaries or the fenestrated capillaries have channels that permit water and electrolytes to pass through this capillary barrier. And even though continuous capillaries are considered tight capillaries, at the intercellular junction between two endothelial cells, as depicted in this green portion of the slide, the cleft that is between the two cells is indeed permeable to water and to electrolytes. There are openings that permit the water to flow. And in fact, the water flows under what we call bulk flow conditions, following Poiseuille's equation for flow. So the flow of water through these channels, you can think of them as being channels, much like a capillary itself, although much smaller. This bulk flow of movement of fluid and electrolytes is governed by the pressure difference across the endothelial barrier and also the resistance of these channels or the pores. Now let's look at the hydrostatic and oncotic forces that determine the movement of water through these intracellular clefts. First, let's look at a capillary here. And inside the capillary, there is a certain pressure. We call that the capillary hydrostatic pressure. Outside the capillary, in the interstitium, there is another pressure. That's a hydrostatic pressure, and we'll call that piece of I, or the interstitial capillary pressure. Normally, in capillaries, fluid is moving out of the capillaries by a process that we call filtration. So fluid is leaving the plasma space, passing through the capillary barrier into the interstitium. And this is primarily driven by the hydrostatic pressure gradient. We have a pressure gradient here because capillary hydrostatic pressure is normally quite a bit higher than the interstitial hydrostatic pressure. And because this pressure is higher, there is a gradient of pressure that permits now or drives flow of water and electrolytes across the capillary barrier and into the interstitium. So the difference between the capillary hydrostatic pressure and the interstitial pressure is the driving pressure to move that fluid across the endothelial barrier. Well, what determines capillary pressure, or specifically in the context of this slide, the mean capillary pressure? I have a model here showing a pair of capillaries here and a pair of capillaries here. These capillaries are being derived from terminal arterioles, and which are derived from a small arteriole. These vessels in the red are what we call the resistance vessels that are then providing the flow to the capillary system. And then the capillaries drain into small postcapillary venules and then into larger venules. And in the blue here, this represents the postcapillary resistance to the flow. Now, knowing that the blood flow through this system is the same at the precapillary side as it is in the capillaries, as it is in the postcapillary side, assuming that there's no loss of this flow, we can set up a mathematical relationship by which we can derive capillary pressure, mean capillary pressure. If the arterial pressure were 100 millimeters of mercury and the venous pressure 0 millimeters of mercury, and if the precapillary resistance R sub A happened to be the same as the postcapillary resistance, then the mean capillary pressure would be exactly halfway between the arterial pressure and the venous pressure. But in fact, capillary pressure is much lower than the mean between the arterial and the venous pressures. And the reason for that is that the precapillary resistance, R sub A, is much greater than the postcapillary resistance. And the way that we can model this mathematically is to say that capillary pressure is equal to the ratio of the postcapillary resistance divided by the precapillary resistance times the arterial pressure plus the venous pressure divided by 1 plus the ratio of the post to precapillary resistances. Now, once again, going back to what I said just a moment ago, if these two resistances are the same, then this ratio would be 1, and therefore the capillary pressure would be halfway between the arterial and the venous pressure. But because this ratio is less than 1, that means that capillary pressure is going to be less than that pressure which is halfway between the arterial and the venous pressure. In fact, in most tissues of the body, at least as an average number goes, the post to precapillary resistance ratio is about 0.2. So when you include that ratio in here, the equation now is capillary pressure is equal to 0.2 times the arterial pressure plus the venous pressure divided by 1.2. And looking at this mathematically, that tells you that a given change in arterial pressure is only about 1/5 as effective in changing the capillary pressure as an equivalent change in venous pressure. So venous pressure is much more important in determining capillary pressure than arterial pressure. Arterial pressure has to change about 5 times more, or to a 5 times greater value than a given change in venous pressure, to exert the same influence on capillary hydrostatic pressure. Let's summarize this and give an example. What will cause capillary pressure to increase based upon the relationship shown here, as described in the previous slide? Well, capillary pressure is increased by an increase in arterial pressure. If you increase the pressure here, this will cause capillary pressure to rise. However, once again, let's say arterial pressure increases by 20 millimeters of mercury. That would only increase capillary pressure by about 4 millimeters of mercury because of the high precapillary resistance. Also, we see that if we have an increase in venous pressure, if this pressure increases, capillary pressure will rise. You can think of it as being, if this pressure increases, that pressure is transmitted back to the capillaries and this pressure is going to rise. Another way that we can increase the capillary pressure is if there is a decrease in the precapillary resistance. So if R sub A decreases, that would lead to an increase in capillary pressure. And that occurs with arterial vasodilation, because when this falls, the denominator in this ratio decreases, so the ratio increases. And so when these vessels dilate and decrease their resistance, arterial pressure has a greater influence on capillary pressure. And finally, if we increase postcapillary resistance, if we constrict these vessels, or occlude them mechanically, for example, this would also increase the capillary pressure. It would do so by increasing this ratio here. All these changes, all four of these changes, any one of these or all four of them together would lead to an increase in capillary fluid filtration, because you will be increasing the hydrostatic pressure gradient across the capillary wall. Let's apply this now to renal hemodynamics, because I think that this principle of pre- and post-capillary regulation of capillary pressure is very well illustrated in the kidney. This is our model system that we saw in the previous slide, and this is a cartoon figure looking at the vascular anatomy of the kidney. Within the kidney, coming off of the renal artery, there are subsequent arteries, smaller arteries that are coming off of the renal artery, and I've shown here the arcuate and then the interlobular artery, giving rise to an afferent arteriole. The afferent arteriole you can think of as the terminal arteriole then that branches into a tuft of glomerular capillaries. Coming out of this tuft of glomerular capillaries is what we call the efferent arteriole. So instead of going into a vein, as we showed here, we're going into another efferent arteriole. And the reason we call it an efferent arteriole is that this efferent arteriole subsequently divides into capillaries again, and at the level of the proximal tubule, and forms what we call peritubular capillaries. So the precapillary resistance in the kidney would be the afferent arteriole and everything proximal to the afferent arteriole, including the renal artery. Those vessels would comprise the precapillary resistance. The postcapillary resistance is primarily the efferent arteriole and then the subsequent peritubular capillary system and then their venous drainage. So let's summarize what happens within the kidney to glomerular capillary pressure. Glomerular capillary pressure would be reduced if we have afferent arteriolar constriction. If this vessel constricts, that would increase the precapillary resistance. If you increase the precapillary resistance, that will reduce the pressure downstream in the capillaries. Or if you have renal artery constriction. On the other hand, we can also have a reduction in glomerular capillary pressure occur through efferent arterial dilation. Normally, this efferent arteriole has what we call vascular tone. It's partially constricted under normal conditions. But if a condition arises where this vessel dilates, that would cause reduced postcapillary resistance and a fall in glomerular capillary pressure. And finally, another way in which we can have a reduction in glomerular capillary pressure occur is through a fall in systemic arterial pressure. So any of these changes here would cause a reduction in glomerular capillary pressure. Now let's turn our attention to another factor that is very important in determining the movement of fluid across the capillary. We've only looked at hydrostatic pressures, but there's another type of pressure that we have to talk about, and that is an osmotic pressure. If we have a little model system here where we have two reservoirs containing sodium chloride of equal concentration, so 150 millimolar sodium chloride here and 150 millimolar sodium chloride in this reservoir, and initially we just have a barrier between the two reservoirs that's completely impermeable to the water. Now, if this were a permeable barrier, and if all we had were equal concentrations of sodium and chloride, there would be no difference in osmotic pressure between these two solutions. And so even if we made this barrier permeable to the water but not the sodium chloride, there would be no net movement of water across that barrier because the concentrations of sodium chloride would be the same. But if we were to add a protein to this reservoir on the left, and the protein we're adding is albumin, now we're setting up something different. We have other particles, other molecules within this that contribute to the osmotic pressure. And now let's do a little experiment. In this experiment now, let's take this membrane that is separating these two reservoirs and make this membrane permeable to water and to the electrolytes. And if we do that, and at the same time I should add that it's impermeable to the albumin, to the protein that is in this reservoir, as shown here, it cannot get through that barrier, then it is the protein that will act as an osmotic draw for the water and the electrolytes to move from this chamber over into this chamber. As fluid and electrolytes move from this chamber into this chamber, the water level or the fluid level will rise. And pretty soon we're going to have a difference in the hydrostatic pressure level between these two reservoirs. And if we were to continue this in this experiment, an equilibrium would be achieved where this level would no longer increase and this level would no longer decrease. At that point of equilibrium, this hydrostatic pressure difference between these two chambers is equal to the osmotic pressure that is generated by the albumin. And because this osmotic pressure generated by the albumin is related to this large protein, we call that an oncotic pressure or a colloid osmotic pressure. And indeed, in the capillary system of the body, it is the presence of the protein within the plasma that serves as the osmotic force to move water across the capillary barrier. It's not the sodium or the chloride or the other electrolytes that are in the plasma or outside of the plasma in the interstitial fluid, because the electrolytes, along with the water, can freely move across the capillary barrier, but the protein cannot. So as I just stated a moment ago, capillaries, like the illustration in the previous slide, capillaries are permeable to water and electrolytes, but relatively impermeable to albumin and other plasma proteins such as fibrinogen. Therefore, the osmotic pressure that is involved in the movement of fluid across the capillary is referred to as the plasma oncotic pressure. And we abbreviate that pi sub c for capillary or plasma oncotic pressure. The pressure outside the capillary in the interstitium is called the interstitial pressure, oncotic pressure, or pi sub I. Because the oncotic pressure and protein concentration, and therefore the oncotic pressure, is greater in the capillary than it is in the interstitium, there is a net gradient, oncotic gradient, that is now bringing water and electrolytes back into the capillary from the interstitium. And this is called reabsorption of fluid. So this oncotic gradient acts to reabsorb the fluid from the interstitium into the capillary. So as we saw in the previous few slides, there is a hydrostatic pressure that is trying to drive fluid out of the capillary. There is an oncotic pressure that is trying to reabsorb the fluid back into the capillary. So the net driving force for fluid movement across the capillary is very simply the difference between the hydrostatic gradient, P sub C minus P sub I, as shown here, minus the oncotic pressure gradient, which is pi sub C minus pi sub I. Now neglect the sigma just for a moment here, or just assume that it is 1. So the difference between hydrostatic pressure gradient and the osmotic or oncotic pressure gradient is the net driving force. If the net driving force is greater than 0, in other words, if the hydrostatic pressure gradient is greater than the oncotic pressure gradient, then fluid will filter across the capillary wall into the interstitium. If the net driving force is less than 0, meaning that capillary hydrostatic pressure gradient is less than the oncotic pressure gradient, then there will be a net movement of fluid from the interstitium to inside the capillary. Now I talked about this little sigma here. This is what we call a reflection coefficient, because we have assumed so far in our discussion that protein cannot pass across the capillary barrier. Well, that's really not an accurate assumption. Now, it holds relatively true for continuous type of capillaries, and even the fenestrated capillaries such as found in the renal glomeruli. But different capillaries will have a different permeability to the protein. So if a capillary barrier is completely impermeable to the protein, then the reflection coefficient is 1, and so we can ignore it. And for most capillaries, especially continuous capillaries, the reflection coefficient is greater than 0.9. So it's pretty close to 1. But if you were to go to, let's say, liver sinusoids, where you have these large junctions between the endothelial cells, well, obviously protein can pass through those. And so that is and because protein now can move across that capillary, the capillary barrier, that's going to reduce the net osmotic force for fluid movement, because that osmotic force depends upon the species being impermeable, and there is a concentration difference across that membrane. So we saw on the previous slide that the net driving force determines whether or not there is fluid filtration or fluid reabsorption across the capillary. But let's say we have net fluid filtration occurring. How much fluid filtration will occur? If you were to quantify the fluid filtration in so many, let's say, microliters per minute or per second, or whatever quantity that you want to apply to this, in other words, some volume of fluid per unit time, we refer to that as the fluid flux. The fluid flux is usually abbreviated as J. The flux of fluid is going to be related to the net driving force, which is our hydrostatic pressure minus our oncotic pressure gradient, multiplied of course by sigma. And it's also directly related to the surface area available for filtration. So if you have a large number of capillaries, you have a greater surface area for filtration, so you're going to filter more fluid across the capillaries. And it's also related to the capillary filtration constant. That has to do with the permeability of the capillary to the fluid. So fluid flux, therefore, which is what we call the Starling equation for fluid exchange, is equal to the capillary filtration constant times the surface area available for the movement of fluid. And that multiplied by the net driving force for fluid movement. It turns out that renal glomerular capillaries have a relatively high filtration constant and a rather large cross-sectional area. That, coupled to a large net driving force, means that through the glomerular capillaries there will be a large movement of fluid. Another concept that we need to consider is the fact that capillary pressure is not the same value at every point along a capillary, because a capillary is a vessel, and so because it is a tube, it offers a certain resistance to the flow. So if you have a certain flow along that capillary and the capillary has a certain resistance, well, there will be a pressure drop from the arteriolar end of the capillary to the venular end, and that pressure drop is equal to flow times the resistance of the capillary. Just to give you some numbers that are generally applicable in the body, the arterial end of the capillary might have a hydrostatic pressure of around 35 millimeters of mercury, and at the venular end it may only be 15 millimeters of mercury. And so along this particular capillary, which would be illustrative of what might be found in skeletal muscle as an example, there will be a 20 millimeter of mercury pressure drop from the arteriolar end to the venular end of the capillary. So there is a longitudinal or an axial gradient of capillary hydrostatic pressures as you move along the length of the capillary. Because there is this longitudinal gradient and the capillary hydrostatic pressures are higher at this end, you can expect that there would be a greater filtration of fluid at the arteriolar end than at the venular end, where the capillary hydrostatic pressure is low. In fact, as we'll see in just a moment, at the venular end, you may not have any net filtration. You may have net reabsorption occurring because of the relatively low value of the capillary hydrostatic pressure compared to the oncotic pressure gradient across the capillary barrier. So when we have filtration that occurs along the length of a capillary, as I just mentioned to you, filtration will generally be higher at the arteriolar end of the capillary. Well, let's consider for a moment what this would do to the concentration of albumin within the capillary along its length. If we start to lose fluid across that capillary wall, that fluid is coming from the plasma. And because the albumin cannot move across that wall readily, there will be a concentrating of the albumin as along the length of the capillary. So at the arteriolar end of the capillary, the albumin concentration will be lower than at the venular end of the capillary, as shown by these yellow circles in the diagram here. And if the albumin concentration is higher at the venular end, that means that the oncotic pressure is higher at the venular end. So as capillary pressure falls, hydrostatic pressure falls along the length of a capillary, we find that there is an increase. In the oncotic pressure, a longitudinal gradient for the oncotic pressure. Now, just how important is that? We often neglect that, or just, do not consider it as changing very much. We assume it's constant, but it's not always constant. It depends upon the amount of fluid that is leaving the capillary. The greater the filtration fraction, the greater the increase in protein concentration along that capillary. Now, filtration fraction is equal to the net filtration rate going across the capillary wall divided by the plasma flow rate. In other words, it's the percent of capillary plasma flow filtering across the capillary wall. For most capillaries in the body, it's rather low, typically even less than 1%. And so if filtration fraction is less than 1%, the concentration, the increase in plasma protein concentration is negligible. But if you have a capillary that has a relatively high filtration fraction, as occurs, for example, in renal capillaries, where the filtration fraction may approach 20%, that will cause a significant increase in the oncotic pressure at the venular end of the capillary, which will alter the balance between filtration and reabsorption. This diagram summarizes a lot of what we've just talked about. Here's the Starling equation, which is showing fluid flux is equal to the filtration constant times the surface area, then times the net driving force. And I have a model system showing an arterial giving rise to a capillary and then going into a venial. And we're going to make a couple little assumptions here. We're going to assume, just for this slide, that interstitial hydrostatic pressure is 1 millimeter of mercury. We were going to assume that oncotic pressure in the capillary is 25, oncotic pressure in the interstitium is 6, and that sigma is 1. So we can plug those values in here. Now, if the capillary hydrostatic pressure entering the capillary at this point right here is 30 millimeters of mercury, shown here, and the capillary pressure at the venular end of the capillary here is 15 millimeters of mercury, which is a 15 millimeter of mercury longitudinal gradient, then if you plug in these numbers and solve for the net driving force, you will see that the net driving force will decline along the length of the capillary. And once the hydrostatic pressure reaches a pressure that is significantly low enough, then the net driving force becomes less than 0 because of the high capillary oncotic forces. And so perhaps at this point in the capillary, as shown in this model, from that point on, you will have a net reabsorption of fluid occur. So in this lecture, we have examined several major concepts. We've looked at how the capillary type affects the fluid movement. We've looked at hydrostatic and osmotic forces and how they determine fluid movement. How precapillary and postcapillary pressures and resistances affect capillary pressure. We've seen how longitudinal gradients of hydrostatic and oncotic pressure in capillaries can also alter the fluid movement. And finally, we put this together into a Starling equation that helps to describe the movement of fluid and the physical forces such as hydrostatic forces, oncotic forces, and the characteristics of the capillary wall itself and how that determines the net fluid movement across the capillary.